I guess we'll get started. Do I unmute this or do you guys control the Zoom? Okay, terrific. Well, thanks everybody for coming out. And those of you online, let's see how many are online. I don't have 29 online. So this is a hybrid meeting. So we'll have a mix of in-person and online presenters. This is the master slide deck, so I'll control it. So if you're presenting online, just say next slide. Also, if you're here, say next slide, or you can run it on the actual keyboard itself. So without further ado, we don't have a keynote this year, but we do have the Disease Liaison Committee reports. We also have Dr. Kachnik, our executive officer, and also Henry Park, who I think is running a little bit late. So he may do his trial concept, if everyone remembers from spring, the Simon study. So he'll represent that sometime during his lung thing. But without further ado, Dr. Kachnik.
Hi, everyone. Hi, everyone on Zoom. Good afternoon. Hope everyone went to the plenary. I just wanted to remind you of a few things. I'm actually doing the slides on the Zoom. That's not going to work. So I think you all know now that we can generate our own concepts. We actually had a committee that did this, and I don't know, Dr. Yu, were you going to announce this or did we already? Well, anyway, so it was Leslie's, right? Yeah. So Dr. Ballas's bladder concept for bladder preservation was chosen. Although I have to say the concepts that we received were all meritorious, but we can only choose one, and their committee was very, very keen on that one as well. So I don't know if she's on, but congrats. The work now starts. We always have an opportunity to do secondary analyses. Oh, skipping one, but I'll go back to that. There is so much data that is not used, and a lot of the trials, especially ones in the past, big ones, have had radiation on it, and the images and the DVHs are kept in IROC, Rhode Island. The Rhode Island folks are our advocates. They're often here. Do we have anybody here today? Hello.
I'm on the call.
I've actually gone there to review things and to work with them, and it's been a great process. So we could, maybe for one of our next committee meetings, we could is this something you can do, like have a list of what studies that you have images for? I mean, our radiation treatment images.
Yeah, I can provide that for you, Lisa.
I think that would be great, because then we all could look at it and think about questions. So anyway, so think about that. But we are also very important co-investigators when we have radiation on trials. So for those of you that are liaisons and you'll be presenting, keep your ear out when they're talking about radiation, or if there's a trial that should have radiation and it doesn't, speak up. And then don't forget to report back to us. So also travel grants, and anyone on Zoom or in the audience use the MAD money this time? All right. Oh, see, I must have told the Columbia people. All right. So I'll tell everybody, you could apply, especially since most of you are not senior members, for travel grants at any time if you're institution doesn't pay for you to come and you have to use kind of your own money. So please, we can help you navigate that. Reach out. It's basically all the time. I'm sorry if SWOG doesn't do a good job in advertising that, or maybe you miss the emails that say that, but there's always for our committees a couple slots for travel grants. And then, as I always do, the Hope Foundation grants that are coming up. So the first one is a $50K seed grant that's actually due soon. And this is preliminary research that could hopefully then inform a clinical trial or a trial associated project. Again, that's due December 1st. And then to the right, that's the next one due. It's the biggest one, the Hope Foundation Impact Award. That letter of intent anyway is due in January, so you have a good amount of time. And that's really looking for something that's very innovative that again would inform another trial. So we're happy to mentor anyone if you guys have ideas on these things. We have had folks from our committees that have been successful for actually all these awards. The next one is the Coltman Fellowship. I don't know if you were here yesterday for the translational plenary one. The physician who spoke first had gotten that, and that's a 2-year mentored fellowship for $50K a year. So typically more junior people. And that's to kind of help buy down your time so that you can either do your clinic or laboratory research. And to the right, also due in March, is Career Engagement Award. And that's also a 2-year $50K award, again, to try to buy down your time from your department. And so recent news, I'm sure everyone knows that there's a new NCI director. And the nice thing is she's very well informed on all of the cooperative group functions because she was the prior chair of Alliance. So that's great for all of the group chairs, whether it's here at SWOG or NRG, because when they have issues, they have someone that they go to that actually knows the process. The next one is SWOG group chair elections. So if you know anyone that wants to be a candidate, please nominate them to Mike LeBlanc. The deadline, and that's our statistician director here, and the deadline is December 1st. And then just for those that are not aware, we actually had a presentation at GI this morning. SWOG's really been moving forth with their DEI efforts. And in the newsletter last week, Dr. Blanky announced our new vice chair, and that's Don Dixon, who was our chair for the digital engagement. And I think he's probably stepped down because this is a big role. Anybody have any questions that I could help with? You see me all the time on the monthly meetings too, but if you have anything, honestly, just reach out. All right. Thank you.
Thanks, Dr. Kachnik. And I think Dr. Kachnik's being very modest about the trial concept that was approved to this committee because it wouldn't have happened without her advocacy at the executive level. You know, kudos for that. I also think she would make a great SWOG. Nope. No, okay. So don't do that. Okay. All right. Okay. All right. Okay. All right. I'll keep my mouth shut. All right. Next is Henry Park has a trial concept that we heard about last time. Going to hear more about it.
Thank you very much. Thank you. So this has been, we've been working on this ever since the last meeting for quite a bit as well with Megan Daly as well as Brad Perez. So thank you all for your help on this. We're still working through some things, and we had a chance to discuss it with the lung disease group, the working group last night, as well as with the surgical and radiation subcommittee this morning. So we have some feedback since then as well, but which I haven't put in here yet. But I'd love to hear any feedback. If you have any feedback from this room as well, we'd love to hear it. Disclosures here. For stage 3A and 2 non-small cell lung cancer, we really have a lot of options at this point. You know, we know that you can do surgery first and then give chemo RT, or chemo IO afterwards. You can start with chemo first and do either chemo then surgery, chemo RT then surgery, or chemo IO then surgery. You also have even for people who can get surgery, you don't have to do surgery. So you could do chemo RT alone, chemo RT then IO, or chemo RT and IO altogether. So how do you know really what the best combination is for these patients? So we know from the INT 0139 trial that if you randomize to chemo then RT versus and then surgery versus chemo RT alone to full dose, which is what they did back here. Excuse they found the overall PFS was improved in the chemo RT then surgery arm compared to chemo RT alone, but that there was no difference in overall survival. In an unplanned post-hoc analysis, there was improved overall survival in the patients who actually got lobe, but not those who got pneumonectomies. So this, this led some people to believe that potentially we should be considering chemo RT then lobectomy in certain patients who can't get surgery, but those who need pneumonectomies perhaps not. And other people felt like, this was a negative trial. Ultimately, did not show overall survival benefit to surgery, and that maybe chemo RT should be a standard of care, even for those who can technically get surgery. So here's a SAC trial here, which looked at, and there's been other trials here looking at, if we do surgery, then do we need the radiation part beforehand, or could we just skip the radiation and do chemo alone? This is one such trial here where they did chemo, then RT, followed by surgery versus doing chemo and surgery. Ultimately, there was the overall response to chemo RT was higher, but there was no difference in the primary outcome of event-free survival. No difference in post-op complications, fortunately. And the overall survival did favor the chemo RT arm, but it was not powered to detect that difference, and overall did not show a difference there statistically. So to sum up, the kind of older work on this, really an unclear role for surgery, but possible after chemo RT, even when resectable. If you were going to do surgery, then consider lobectomy afterwards. Now, if you're going to do lobectomy anyway, then consider doing either neoadjuvant chemo or neoadjuvant chemo RT. Now, in the unresectable population, we all know this study, the Pacific study, chemo RT, do you add immunotherapy afterwards? The answer was resounding yes, if you can. So by doing consolidated durvalumab afterwards, that increased the 5-year survival. Now the PFS from 33 to 44%. I'm sorry, from 33% to 43% for 5-year overall survival. And then the PFS went from 19% to 33%. These were all the best numbers we've still seen to date for the 5-year data for stage 3, really in any context. So now in resectable patients, overall, so what does this mean for people who can't get surgery? Now, if the chemo RT arm is doing better than it did before with chemo RT and IO, then should people even be getting surgery at all? Should we just move everyone to Pacific at this point and do do chemo RT, then IO afterwards, versus doing chemo RT then surgery? So the Checkmate 816 study did not answer that question, but it did answer a different question, which is if you're going to do surgery anyway, then do you add immunotherapy to the neoadjuvant chemo? So here's a phase 3 here that looked at patients with stage 1B through 3A non-small cell lung cancer. You can either get chemo or radiation afterwards, but not immune therapy. So they got, but then everyone got surgery after the neoadjuvant therapy. The past CR rate was much higher, went from 2% with the chemo group to 24% in the chemo IO group. And then you can see here that those who got chemo IO had a much better EFS at the 2 and 3 year mark, at the 2-year mark than those who got chemo alone, around 63%. So then they did subgroup analysis. So this is what I didn't show last time. This was coming out at the time of SWOG last time. Was the subgroup analysis. So this showed that stage 3A patients and high PD-L1 patients were actually the subgroups that benefited the most from chemo IO, which may not be too surprising. But you can see here, even among the 1B through 2, if you look at them overall, that it actually crossed over 1, the hazard ratios here, whereas 3A was really the driver, it seemed. And if you're looking at PD-L1 status, if you look at those over 50% that may have been driving it as well. If you look at the stage 3 EFS, then you see pretty similar numbers. It's pretty small here, but ends up around 63% also at the 2-year mark for EFS. OS did not cross the boundary, the overall boundary for statistical significance, but as you can see from the p-value here, was very much trending towards that direction. They just picked a really conservative p-value there. So overall, what's very interesting from here as well are some of the biomarkers, or at least some overall some proxy outcomes. So if you look at PAT-CR, if you look in green here, those who got chemo-nivo and had a PAT-CR did this well, and those who did not have a PAT-CR did this well, right? So really big difference there. The chemo arm, only 4 people had a PAT-CR, but those who did, did excellent. And those who didn't, really pretty similar to those who got chemo IO and did not have a PAT-CR. So this really was a good indicator of how people were going to do at the time of surgery. But it wasn't clear that it was the surgery that's doing this, right? It's really the response to the chemo IO really was the indicator. ctDNA was also another indicator, not as clean, but if you compare the green here versus here, that's those that ctDNA clearance fully and those who did not for the chemo IO patients. So NATAM2 has come out since then as well. So this is really new data over the last couple of months. So this was the JCO article here was a single arm trial here of 46 patients with stage 3A. So specifically focusing on the 3A patients who got neoadjuvant chemo and IO and then surgery. The difference here is that they did give them adjuvant IO as well. At 36 months, the overall survival was very high. It was over 80% at 3 years. And then undetectable ctDNA here was associated with both PFS and OS. So here again, this here was a single arm, but the blue here is the people who had a who had undetectable ctDNA, and those were here had some ctDNA still detectable. So for PFS and OS. So this came out of World Conference on Lung Cancer. Was so here's the 2R study, so the randomized study here, which was chemo IO versus chemo. So again, similar population, except they got adjuvant IO afterwards, and focused really on the 3A patients. As you can see here, most people got lobectomies, but some people got pneumonectomies. It's not something that was common, but about 10% of people did. And then PFS here, overall, pretty similar numbers. You see about 66% overall, which, compared to 63% from the CheckMate 816 study. Of course, we're not doing cross-trial comparisons, but that's something that's overall intriguing is that the overall the curves look very similar in terms of the difference between chemo and chemo IO. PAT-CR, very similar too. I mean, this is pretty remarkable that 3 years, 100% response. The PFS was 100% if you had a PAT complete response rate. For those who got chemo IO or chemo, 100% here. There wasn't a single failure. And then if you had an incomplete response at time of surgery, then the outcomes were quite poor. And most people were still in that arm, in the second one, the incomplete arm. Only about 30 or so percent had a pathologic complete response. So ultimately, this led to a lot more questions than answers, as all trials do. Do we shift our paradigm for resectable patients from chemo plus minus RT followed by lobectomy, or do we do chemo RT and IO that we did in Pacific? But all of a sudden, at our lung tumor boards, we're seeing that we're converting over to chemo IO then surgery, and this wasn't the question, right? This wasn't the study question here, was comparing this to this, but really it was looking at it was looking at this part first, chemo then lobectomy. But what it didn't really look at was the second question of, is this a paradigm really better than doing a non-surgical approach? So again, highlighting here the difference in those who got PAT-CRs versus those who didn't, and both CheckMate and NATAM was quite remarkable. So we know what I really gathered from this is that patients do remarkably well with PAT-CR after chemo IO. They're more likely to get PAT-CR if they get chemo IO compared to chemo. But then still a minority of patients actually are able to get a PAT-CR. And outcomes are still very really suboptimal if they don't have a PAT-CR. The question now is, would chemo RT potentially work even better in a resectable population than it did in Pacific, and potentially even do better than those who got surgery in this population? So what's the optimal local therapy here? And this here is where we're overall trying to go with this eventually, and we're debating about exactly how to get here. But the basic idea would be to start with all clinical stage 3 N2 patients. So anyone who has N2 disease, but it could be 3A, 3B, 3C even. Well, really, actually not 3C, but 3A, 3B, and N2. You could have any number of positive N2 stations. You could have as large of a node as you want in N2. PDL1 can be anything, and then also the resection could be anything you want as well. And we would stratify by those variables. The idea would be to start with chemo IO first, and see if we end up going down this pathway. Arm 1 would basically be the CheckMate, the paradigm of chemo IO then surgery. Or you can randomize to doing basically Pacific in reverse, where you're doing the chemo IO up front, and then hopefully looking at ctDNA as well. And if you're not going to get a PAT-CR, obviously without doing surgery, but hopefully ctDNA can be a good proxy for that as well. And then we do chemo RT for those patients, and then we'll see how people do on that. Now, how exactly we design this is still up for debate, and that's what we've been discussing the last couple of meetings about how to do this. There's one possibility that we start initially with a single arm of doing chemo-nivo followed by chemo-RT, given that hasn't really been done yet. We don't really have any data to show us exactly how people do with that regimen yet. There is a Keynote 799 trial that did look at chemo-nivo for one cycle followed by chemo-RT, and those patients did fine. And actually those people got chemo-RT and IO concurrently with patients who got the upfront chemo-nivo. That's been one criticism so far, is that we need to investigate this arm and provide at least some early data and some feasibility data on that first. The issue with that is that we're not going to see a resectable population, and what we're hoping for in order to not compete with other trials. Let me just come back here real quick, which is that we have competing trials here on in an unresectable setting, looking at concurrent IO with chemo-RT. I guess and this is supposed to close in about a year. They're accruing very well through ECOG-ACRIN. The other trial is the Alchemist study, where you do surgery up front and then you randomize to doing chemo or chemo IO afterwards. But we think this wouldn't necessarily, if we're looking at a resectable population, wouldn't necessarily conflict with any of the current studies out there in unresectable stage 3s. But that being said, is there enough equipoise in the community to randomize between, to give chemo IO first and then to randomize to the local therapy afterwards? And I would argue that there is, that there's not really any data yet showing that this approach that has done well so far is necessarily superior to a non-surgical approach, which a lot of patients do want. And really in general, in the stage 3 lung cancer world, we haven't really shown the added benefit of surgery over anything else. So this is where we're at now. I'm not sure I won't go much into this because we're still debating about what kind of design to show, but we're hoping for a relatively small study first to show feasibility of this approach. Whether or not we find kind of a small group of high volume centers that are going to be willing to randomize for like the initial feasibility study, safety run-in, but also to look for efficacy. And then if we see a good signal there, then move on to a larger study that maybe that we're considering as well. I'd love to hear any feedback since we're still in the process of working on this concept.
Henry, this was a great presentation, especially since I spent my week talking with our thoracic surgeons about why we have no lung volume. So I guess that's my concern with this design. Will you have the buy-in of the surgeons that literally told me like there's no role for radiation anymore in lung cancer? So that was part one. But my part two question is, well, what about the patients that don't have a pathologic complete response? Do those trials have imaging? Can the imaging predict clinically, like at least, 85%, which patients are going to have a pathologic response and which are not? Because then you can take that group of patients and maybe give them radiation. Mm-hmm. And who wouldn't buy into that?
Right. Yeah. And then the other thing we've been talking a little bit about as well is do we add more to the post-op setting for those who don't have a pathological response? Do you do some, and actually this group would be really great to ask this question to, because the med-onc surgeons don't quite understand, I think, the details of port in terms of the volume of disease that we're treating. Because if we just focus on the areas of residual disease, the areas that there was not a path complete response, could there still be a role for post-op radiation in this setting for those with any residual disease? That it would potentially be a different design, but so far I haven't gotten a lot of great feedback from the med-onc surgeons yet, but I think I think that's one possibility. To answer your question about the clinical response and the radiographic response, it's not so far been clear that is a great indicator. I think sometimes seems like there's even pseudoprogression at times, and they take them to the OR and there's actually a pathologic complete response. It's so far been actually very difficult to guess up front whether or not you should do the surgery or not, basically, or if it warrants that. So I think if we had a good biomarker like ctDNA, that may be the key here, right? Is to indicate if they have no residual disease, if you have undetectable ctDNA afterwards, maybe then go for surgery, and if you don't, then maybe go for a non-surgical approach or some kind of variation of that. Dr. Robinson.
Well, Henry, great talk, really interesting study. I can't quite tell. So are you doing any kind of evaluation after the chemo by nivolumab? Like, it seems like an opportunity for biomarkers or prediction or shrinkage, or I don't know if I missed that, but just before randomization.
Exactly. So the idea would be to have ctDNA tested in the beginning, to have it tested after the chemo-nivo at that point, and then before the randomization, and then tested again, right before the actual procedure, the local therapy afterwards again, and then if you have maintenance therapy afterwards. how to exactly incorporate that,
Right, so that's
we're
not, gonna-
not sure.
not gonna stratify for it, but at least gonna observe that.
Actually, I didn't put that in stratification variable, but yes, I think we certainly could consider that too.
What about imaging biomarkers? Just, does it shrink, that kind of thing, PET scan or something else?
Right. So that's the question Dr. Kashnik was I think
Yeah.
getting at it, which is that, so far the experience from the surgeons has not necessarily shown that imaging is a great biomarker yet, at least the conventional CT scans. Now, should we do PET scan? Should we do, are there any other ways we could do this? Potentially. And that's been, this whole, the whole idea of doing kind of interim PET during chemo RT, for example, for lung has been explored a bit as well, and from other groups, something to consider. Thank you. And not everyone here does lung, but I just curious, kind of the general VDOC, point of view on this. Right. Yes, I think we'll probably start going that direction. Yeah. Yeah. And the surgical group actually was, relatively open to this idea. They weren't, I think they weren't overall gung ho, because I think the trend has gone towards just operating on everybody now, but it's not really clear that's the right thing to do. And I think if we can find a surgical co-chair who really still has the right equipoise on that, that would be ideal.
One thing I find is after the keynote results, our surgeons and medical oncologists are kind of interested in using chemoimmunotherapy or even targeted therapy for like advanced 3D, even 3C, as sort of like a downstaging effect. And so in your design, I might consider like upfront randomization to really commit to like, no, I believe this is resectable.
No, that's a good point. Yeah, that's something I've been actually considering pretty seriously. Is just the upfront, either upfront randomization or at least before the restaging scans or the restaging the ctDNA before we launch into that, because I think that's an important point. The other thing I want to bring up was that really the way the surgeons might buy in more is that the people who right now we do send for, with the multi-station NT disease, or they, just have very bulky disease in general, that, right now the way Checkmate did it was, and a lot of people don't, even the surgeons don't realize this, is that they only allowed people in who upfront at diagnosis, the surgeon can say that they are going to do a lobectomy and they're able to do a lobectomy, for example. They're not supposed to downstage and say, well, right now you need a pneumonectomy, but if you have a good response, I'll be able to do a lobectomy, hopefully. Those people were not supposed to be included on the Checkmate study or the NATIM study. Here that would be the same idea, but at least, I think for some departments, we are still seeing that a lot of people are doing the chemo RT route for having multi-station disease, and that's not clear that necessarily should be the case either. So it could go the other way, where the surgeons may actually end up, being able to see more patients as well.
Yes, that was the point I was going to make, that if you allow for downstaging with the neoadjuvant chemo IO, you give the opportunity for the surgeons to make their case stronger, and you give the opportunity for us to make our case stronger about local control. And then you're answering an interesting question.
Yeah.
So I think I would advocate for allowing for downstaging. And then not being able to go for surgery is a really important thing to see, quite honestly.
Yeah, it's an important endpoint. That's part of the EFS endpoint, and that would be, I think that'd be a really good idea. I should solve that part more to the surgeons, that there may be more patients that you might be getting as well if it works out, and that's great. Yeah, and that's great if it is true that surgery is better for those patients, then we should know that too.
Great comments. I would also add, you might want to think about moving your overall survival endpoint up to primary, because people die from surgery. I mean, even in claims data, or on stage 1 disease, people still die of complications, and you might see that overall survival benefit from perioperative complications.
That's a good point. All right.
All
All
right.
right. Thanks very much.
All right. And for the folks on the call, the Zoom, we haven't forgotten about you. We know you're there. And feel free to throw in any questions in the chat, or I think we can hear you if you unmute. We'll hear you like the voice of from above. But Dr. Jagsy, I think, is going to present breast updates.
Excellent. I'll be the voice from above.
And so, Dr. Jagsy, just say next slide, and I'll advance the slides for you.
Okay, sounds great. So I'll take the first slide.
Hold on, we can't hear you quite yet.
Can you hear me now? Somebody says they can hear me. I think you might be on Zoom. Yep, I'm seeing chat bubbles saying on
Now,
Zoom they can hear me.
okay, now we can hear you.
Excellent. I'm the voice from above. I will take my first slide, please. Thank you. You can keep going until I get to an actual content slide. So we've got one open trial in the SWOG system right now, and that is, next slide, please, SWOG 1706, which is the phase 2 randomized trial of a PARP inhibitor administered concurrently with radiation treatment as a radiosensitizing dose versus standard radiation therapy alone for inflammatory breast cancer. So next slide, please. This is a trial whereby patients undergo the standard approach to inflammatory breast cancer, which we all know is a neoadjuvant chemotherapy approach followed by modified radical mastectomy surgery, followed by radiation, and they're randomized to receive either just radiation treatment alone to the chest wall and regional lymph nodes, or that same radiation treatment with a low radiosensitizing dose of olaparib. And the goal is 300 patients. We are slowly making our way through accrual. We're over a third of the way through. We're not at our 5 patients per month that we had hoped, but hanging pretty steadily at the 3 patient level, which I understand is beyond the 50% of planned accrual that is necessary to keep people from getting too agitated, which I guess is good, but we could do better. So for those of you who are in the room, you know, this is certainly an uncommon presentation, thankfully, but is certainly a very important group to capture. And so if you have a patient come in, please do think of this trial, and we will continue to collect samples and have a really exciting database for correlative analyses that are going to be led by Corey Spears. And so, you know, please continue to accrue to this trial. Next slide, please. We've got 2 trials that are in development. Eileen, are you on this call?
She's in the room.
Okay, excellent. I'm going to let Eileen speak about her own trial, if that's okay. And then Corey, I don't know if he's in the room.
Yes, he is. He's in the room too.
So do you mind just sort of forwarding the slides and letting them speak to their own?
Sure.
Yep, perfect.
All right.
So this is my study going through the prevention committee. This is a randomized phase 2 trial of intraoperative radiation therapy in postmenopausal women with low risk DCIS, basically fitting the 9804 criteria. So less than non-palpable women over the age of 50 with screen detected unifocal lesions less than 2.5 centimeters, grade 1-2 ER positive. And we're asking the question of, does IORT add any benefit? So these women who are eligible would get randomized to breast conserving surgery alone versus breast conserving surgery with IORT. Post-pathology would be used to risk classify them based on APBI guidelines. So if they have high-risk features of it being grade 3, larger than we expected, or positive margins, they would go into the cautionary unsuitable risk and be recommended whole breast radiation. And we would primarily look at them for PROs and toxicity. The remaining patients who remain low risk post-path would go on to the low risk group, and we'd look at our primary outcome, which is 10 years in breast tumor recurrence. So next slide gives the updates. So right now, the primary outcome is our in-breast tumor recurrence. Secondary outcomes are looking at toxicity, both physician-reported and patient-reported. We also have photographic assessment for cosmesis and a translational medicine assessment using DecisionRT. And then we're also building into this a mammographic assessment to look at DecisionRT and how it compares with mammographic AI analysis. And so where we are right now is this concept has been reapproved. So we got a new number. It's S2304. That was in September. The PRO committee has reviewed the PROs that we've proposed and made some recommendations for changes, which we're going to adapt. And then we've done financial and feasibility. And so, as well as reached out to Latin American sites, which have expressed interest. So now we're getting ready to present to DCP. So this was submitted and we're hoping to present it soon. Initially, we were thinking November, but they want to do a pre-call before it's brought before the steering committee. So I think the call is going to be in a month, and then hopefully it'll go to the steering committee soon after. That's where we are.
Yay. Congrats.
Okay, and then on the other end of the pre-invasive spectrum, we have invasive disease with patients who have high risk of local regional recurrence. So we had proposed a trial in which a CDK4/6 inhibitor was combined with radiation for women with 4 or more nodes positive or T3 tumors with 1 to 3 nodes positive. Initially, this trial was approved as a randomized phase 2, but then there was some discussion about needing some safety data to make sure that the toxicity with combined agent therapy with radiation was okay. So we have gone back to do a safety run-in phase 1 trial, planning for about 28 patients. Again, the plan is to use ribociclib combined with radiation in women concurrently and not continue in the adjuvant setting except at the treating physician's discretion. So not required to continue the ribociclib in that setting. And the primary endpoint is essentially toxicity and moist desquamation in these patients, as well as neutropenia. That trial has been approved by Novartis. It is funded. We are currently contracting and trying to open. We're hoping to have first patient on trial by the end of the year, really going to open initially at the University of Michigan and a community center out west, and then also out at University Hospitals in Seidman. The plan is once we're completed with this, we hope to come back to SWOG and run the actual randomized phase 2 trial with about 200 patients, which is the plan. And you can go to the next slide. I guess that's it. So,
Thank you.
So we're excited to get the first patient on, excited for Novartis' support of this trial, and hopefully we'll have the first patient on by the time we have a meeting again in the spring.
So hats off to both Eileen and Corey. These trials have been many years in the works and very thoughtfully designed to recognize sort of the spectrum of breast cancer as not a single entity. The next couple of things that I just wanted to mention briefly are champion trials and other groups. Next slide, please. So we've got Taylor RT, as I mentioned last time. The criteria have been amended for eligibility to broaden eligibility. So now it's not just biomarker low risk node positive patients, but it's now biomarker low risk node positive and T3N0 breast cancer. And so we now also include micrometastases as well as T3N0 disease. We've been a little bit more generous in terms of, sort of the time allowed between surgery and start of treatment and chemotherapy and start of treatment, various other efforts to try to make it easier to accrue. And you can see here that accrual is going well, nearly half of planned accrual as of the end of August. But you can also see that the number who've been accrued through SWOG is relatively low. And I think that's partly because people who are accruing at centers that have more than one affiliation are tending to accrue these patients under NRG or a different affiliation. But I would encourage us to try to champion this as much as possible. It is really important. It's a question that needs to be answered. In fact, my analysis that's upcoming at Astro, where I already am, is going to emphasize that as its conclusion slide, as we really need this study. So next slide, please. This is BR007. Dean Shumway is the champion of this. This is the omission of radiation for biologically favorable node-negative patients after breast-conserving surgery. And it's a randomized trial and already has 231 of the 1714 patients accrued, speaking to how compelling this question is. And so please, again, continue to reach out to patients about this. It's a trial that hopefully will identify a strategy to reduce toxicity and burden. Next slide, please. We've also got some other things that are underway. The secondary analysis of radiation therapy use and local regional outcomes by recurrence score and radiotherapy receipt in SWOG 1007, which was the trial that looked at whether Oncotype DX recurrence score would allow us to omit chemotherapy in node positive patients as its primary goal, and was published in the New England Journal of Medicine. Now we've got this secondary analysis that we had planned, and it's being presented as an oral on Monday at 5 p.m. at Astro for those of you who are headed down here. There's ongoing work on genomic signatures and local regional outcomes in SWOG 8814 led by Dr. Spears, and some really exciting work that he's publishing from this work that I think you've all seen, JAM Oncology now, JCO, and ongoing additional work. And then final slide, some concepts that are being envisioned include oligomets and the conservative management of local regional recurrence. And on oligomets, the next slide, this is a slide from Shane Steckline, who kindly provided just an overview. The early talks have led to actually the development of 3 separate subtype-specific proposals that are at various points in early development. And please reach out to him if you'd like to discuss further, but I recognize there's a lot of other committees that need to go, so I don't want to take up too much time. Shane, I don't know if you're on the call or in the room.
Oh, he's in the room. Do you want to
Okay.
say?
If you have time, go for it. If not, I'm sorry that I may have taken up too much time.
Go for it, yeah. Shay's walking up to the mic for those kids.
Awesome.
I will be very brief. Reshma did a great job. So the general schema for all 3 of the sub-studies is basically exactly the same. The goal is to start with intensive multi-agent curative intent systemic therapy based on biologic subtype. The randomization happens after patients have demonstrated at least a partial response to therapy, and then we go forward with the curative intent local regional therapy, ablative SBRT to somewhere, we're still deciding, but up to 5 sites for the triple negative cohort. We're considering limiting that to 3 sites versus no local regional or ablative therapy. And then patients who are randomized to the curative intent arm go on to receive subtype specific adjuvant therapy for a limited period of time. So we have the opportunity to actually demonstrate cure in the absence of indefinite systemic therapy. And then patients who are randomized to the non-curative intent treatment will go on for maintenance systemic therapy that's appropriate for their subtype. So I'll stop there.
Thank you. Okay. All right. Thanks, Dr. Jaxie.
Thank you, guys. Hope to see you soon.
Yep. See you soon. And so next up we have Dr. Tony Wang, who I see online. Tony.
Hi, can you hear me?
Yes.
Okay, thank you. So as some of you may know, the CNS group is a working group where we've had a lot of concepts being floated around. I will present 2 concepts that are the head of our CNS working group, Dr. Ahluwalia, will be pushing forward, and also some select CNS trials that are ongoing. Some have just recently completed accrual, both in the primary brain tumors and brain metastasis world. Next slide, please. So some of you who do CNS may be familiar. This is the Alliance A071801 trial. This is a phase 3 trial randomizing patients with limited brain metastases, one of which has to undergo a gross total resection to single fraction versus fractionated radiosurgery. The primary endpoint is time to surgical bed recurrence. Thankfully, as of recently, this trial has completed accrual as of this month. So we are looking forward to the results. As the PI, Dr. Paul Brown, has discussed, to please provide some of the post-treatment MRI scans for those that have accrued patients on this trial. So we'll anticipate looking forward toward the results. Next slide, please. So this is NRG BN009. This is a phase 3 trial randomizing patients to salvage hippocampal radiotherapy or radiosurgery, or just salvage radiosurgery patients who have a first or second distant brain relapse after upfront radiosurgery. These are patients that that require to have a brain metastasis velocity of 4 brain mets per year. This is led by Dr. Vinay Gandhi and Dr. Michael Chan. This trial is active, and at the moment, accrual for this has been a little low, but hopefully if anyone has any questions or comments about this trial in terms of accrual, please let the PIs know about it, or let me know about it. Next slide, please. So this is NRG BN007. Again, these are select CNS trials. I'm not presenting all the trials that are out there. And certainly we currently don't have any SWOG CNS protocols, but just discussing some ongoing trials that are in the CNS world. So this is a BN007. This is a phase 3 trial randomizing patients with unmethylated MGMT to standard adjuvant temozolomide chemoradiation followed by adjuvant temozolomide, or omitting temozolomide altogether and doing a dual checkpoint inhibitor, ipilimumab and nivolumab. So this trial is accruing very well. and it's currently moving to phase 3. Next slide, please. So the next trial that is currently being discussed with respect to radiosurgery is BN2224. This is led by Dr. Rupesh Kotiches. This is a phase 3 trial of single fraction radiosurgery versus fractionated radiosurgery for intact brain metastases. Next slide, please. The schema is there. Great. Yeah, so these are for patients that have intact brain metastases. So unlike the Alliance trial, where you have to have a gross total resection, these are patients with intact brain metastases of 1 to 8 brain metastases, which have to have a 1 to 3 centimeters in size, and then a DSGPA of greater than 1.5. And then patients are randomized to single fraction radiosurgery of 20 to 24 gray, depending on the maximal diameter of the brain metastasis, or they are randomized to fractionated radiosurgery to 30 gray and 3 fractions, or 27 gray and 3 fractions based on the maximal diameter. And the primary endpoint here is 1 year local control. Secondary endpoints include radiation necrosis, patterns of failure controlled by primary histology. So this is currently in concept and development. So looking forward to seeing where this concept goes. Next slide, please. So this is NRG BN2028. Actually, it has already activated. I apologize for not updating the trial number, but this is a trial by Stuart Burry, randomizing patients to preoperative radiosurgery or postoperative radiosurgery in patients with planned resected brain metastases. Next slide, please. I think the schema is there. Yes, perfect. So in this, this is the schema of BN012. So it's BN012. It's patients that have 1 to 4 brain metastases, of which 1 requires resection. These are patients that then requires stratification to pre-op SRS. The SRS needs to be delivered within 7 days prior to surgery, or they're randomized to post-op SRS to the resection cavity. And then the treatment for that is consistent with Alliance single fraction dosing by volume. Next slide, please. So this is an ongoing Alliance A071702 trial. This is a phase 2 study looking at checkpoint blockade immunotherapy in patients with somatic hypermutated recurrent glioblastoma. Next slide, please. So these are eligible patients. All patients have to have histology GBM, but can be either IDH wild type or mutant, and undergo surgery. Patients that are identified to have high levels of somatic hypermutation on their GBMs will undergo nivo ipilimumab, and if there's more than 1 response, they'll continue on that treatment as planned. Next slide, please. So the next 2 concepts are concepts that are being pushed forward from the CNS working group. This is a phase 2 study of atezolizumab and tocilizumab. So those who are familiar, this is a PD-L1 inhibitor and an IL-6 inhibitor to get radiation therapy in newly diagnosed MGMT unmethylated GBMs. Next slide, please. And this is the schema. These are patients who have maximal safe resection for their glioblastoma that are then given radiation therapy, omitting temozolomide, that are getting atezo and tocilizumab followed by atezo-tocilizumab. And the key eligibility is that they need to have unmethylated MGMT, sort of as a justification to omit a temozolomide. And the primary endpoint here is 1 year overall survival. So a lot of good feedback from prior CNS working group meetings, and I think we're going to be moving forward with this concept. Next slide, please. So this is the other concept from the CNS working group led by Dr. Ahluwalia. This is the TRC102 drug and temozolomide in patients with refractory first-line glioblastoma. Next slide, please. So this is intended to be a phase 1-2 study of TRC102. For those that are familiar, TRC102 is a basic excision repair pathway inhibitor. In Dr. Ahluwalia's recurrent GBM, in patients that had MGM promoter methylation tend to have a better signal prognostic for TRC102. And so this is being promoted for, this is being introduced for newly diagnosed GBM for MGMT methylated patients to undergo standard chemoradiation temozolomide followed by adjuvant TRC102. to validate the DNA damage response pathway. And so with that, that's the end of my talk on the CNS concepts.
Thanks, Dr. Wang. Any comments from the room or Zoom? All right. Oh. Chat. Sorry. Okay, great. And Dr. Horowitz. Wherever you want. Okay. Thank you. Do you want to run? Great.
All right. It's a pleasure to present some of the GI committee updates. Unfortunately, there aren't any SWOG trials currently open that feature radiation as one of the primary modalities. We have a couple trials that are in development but aren't quite there. So in terms of open trials that we're championing, we have these that I'll be discussing. So the first is NRG GI006, which is a phase 3 randomized study of proton beam versus IMRT for the treatment of esophageal cancer. Again, you can see the two arms here, which the patients are receiving proton beam or IMRT with carboplatin and paclitaxel, followed by surgery after their chemoradiation. Steve Lin is the PI for this. This has actually been accruing pretty well. They're about a third accrued, and the primary endpoints here are co-primaries of overall survival and then grade 3 or greater cardiopulmonary toxicity. There are a lot of other secondary endpoints that they're evaluating here. ECOG is doing a trial similar to what Dr. Stecklein was discussing for the breast. It's a phase 3 study evaluating consolidative radiotherapy in patients who have oligometastatic HER2 negative esophageal or gastric adenocarcinoma. I think that this is an important trial to evaluate, and you can see it's a little bit complicated because there are multiple arms that are available. The original setup for this was FOLFOX versus CAPOX or CAPOX, and then randomization to consolidative radiotherapy to the primary site at the investigator's discretion, and then up to 3 sites of metastatic disease. We know that these diseases are responsive to immunotherapy, so there's been a recent update to the protocol to allow for patients to receive nivolumab before and after randomization. And then there's another update to the protocol allowing for enrollment of patients after they've received 4 months of systemic therapy, trying to liberalize patients who are able to get this treatment. But really it's evaluating ablative radiotherapy to the primary site and to up to 3 sites of metastatic disease. Now, the primary endpoint of this is overall survival with secondary endpoints of safety and tolerability. I'm the SWOG champion for this, and this study has been accruing, unfortunately, very poorly. Only, I think, 2 subjects in the past 6 months since we last presented this. And so we need your help in the Radiation Oncology Committee to try to advocate for this trial and to enroll, because I think it's an important question. And again, the recent amendments really liberalize the patients who are able to get enrolled on this. So keep your eye out for these, and please open this trial. So the backbones are FOLFOX or CAPOX, and then at investigator discretion, you're able to get IO or not. They recommend, obviously, if you have high TMB or you have high TPS, that you get Nivo, but you're not required to get it on the study. And then if you identify these patients after they've received systemic therapy, you can still randomize them.
Is it up to 5 mets?
3.
Oh, 3 years.
There's another NRG trial, GI003, which is again a phase 3 randomized study of protons versus photons for hepatocellular carcinoma. You can see the schema here, stratified based off the number of fractions that are planned, 5 versus 15, and presence of tumor vascular thrombus. And again, patients are randomized to protons or photons. Ted Hong is the PI for this, and again, the primary endpoint is overall survival. This has actually been accruing pretty well also. And then in the anal cancer space, the DECREASE study, looking at early stage, low risk patients with T1 or 2 tumors less than 4 centimeters, node negative, looking at de-escalating both radiation dose and number of cycles of chemotherapy that are used. This is a randomized phase 2 study with the primary endpoints of disease-free survival and anorectal health-related quality of life. Jen Dorth is the PI. James Murphy is the SWOG champion of this. And this, again, has been accruing very, very well with 124 subjects enrolled to date. So that's what I have. Thank you.
Thank you, Dr. Horowitz. Thank you. All right, moving right along. To you, first of all, we mourn the passing of Dr. Nick Vogelzang, who was a giant in the field of GU oncology and at SWOG in particular. And earlier today, there was a wonderful first Vogelzang symposium on bladder preservation and bladder cancer. So something positive for radiation oncologists. There's increasing interest in bladder cancer, bladder preservation. So Leslie was here. I think she had to step out, but as Dr. Kashnik mentioned, this was the concept that is moving forward within our committee, largely because of the there's a strong enthusiasm from the GU committee, and because this is our first concept, we really need that structural support. So basically, the idea is that patients who have a complete response or minimal residual disease, like T1 disease, for example, after neoadjuvant chemotherapy are then randomized to IO versus RT-IO. And hopefully we'll get this rolling. Ongoing trials, SWOG 1802 is a randomized study looking at standard systemic therapy versus standard systemic therapy plus definitive treatment of the primary tumor and metastatic hormone-sensitive prostate cancer. That's accruing reasonably well, although I think the radiation piece of that is accruing better than the surgical piece. So if you do have folks at your institution who are interested, please try to enroll. SWOG 1806 is a phase 3 randomized study of chemoradiation with or without atezolizumab for bladder. And this is actually accruing very, very well, to the point where we're starting to think of what the successor study is going to be. We kind of have to see where the ball is going to go and try to predict which is going to be the winning arm. But this is accruing very, very nicely. Jason Estathiou is the NRG chair. So anticipated closure in less than a year. Other SWOG trials that are ongoing, this is PROBE. It doesn't involve radiotherapy, so I'll just be really quick. It's a phase 3 trial of immunotherapy-based combination therapy with or without cytoreductive nephrectomy for metastatic renal cell carcinoma. SWOG 2011 is a randomized study of gemcitabine, avelumab, and carboplatin versus no neoadjuvant therapy preceding surgery for cis-ineligible muscle-invasive urothelial carcinoma, so that you can have, I think you can have ureteral cancer, upper tract cancer, that sort of thing. It's accruing very slowly. SWOG 1937 is a phase 3 study of eribulin with gemcitabine for metastatic urothelial carcinoma that is refractory or ineligible for IO. This is also in danger of closing, but again, there's no radiation arm, but it's for us to be aware of. SWOG is championing a bunch of studies from NRG. GU009 is the NRG flagship for high-risk disease. Hong Zhang sent me these slides. And it uses Decipher to stratify high-risk disease into a de-intensification study or an intensification study. The high-risk de-intensified randomizes between shorter course hormones and longer, whereas the intensification study adds on apalutamide. This is actually accruing like gangbusters, and Paul Nguyen is the PI of this study over at NRG. So this is a very straightforward study to accrue to. So I encourage everybody, it will get your study numbers up. GU10 is the intermediate risk equivalent. guidance study. This is Neil Desai at UT Southwestern. It also uses Decipher to stratify into an intensification and de-intensification study. The de-intensification study, I think he flipped those, is RT alone versus RT for short-term hormones. And the intensification study adds on darolutamide. And then GEO11 is Promethean. This is the oligometastatic study at NRG. It uses relugolix in combination with a metastasis-directed radiosurgery. So it's SABR versus SABR and relugolix. The cool thing is this is blinded and will involve placebo. We'll stratify between bone only versus involvement of nodes and PSA doubling time and a PET scan. Primary endpoint is radiological progression-free survival. It's an interesting study for those of us who are interested in like oligometastatic radiosurgery. And I'll just move on quickly. Relugolix is an interesting medication. It's the oral GnRH antagonist and seems to be very well tolerated as well versus placebo. Dose prescriptions are relatively pragmatic, 1 to 3 fractions, up to 5 fractions. And so please consider opening this study at your institution. I think accrual has been a little slow for this one. And finally, NRG-GU12 is the Samurai study. It's IO versus IO plus SABR of the primary tumor. This just opened. The IO side is very pragmatic. As you know, for renal cell carcinoma, there's like a million things you can do, different IO combinations. So this is pragmatic to all of those possibilities. All right, Dr. Park.
All right, thanks very much. So for outline here, we'll talk about the 4 studies that we have open to the lung group that involve radiation. The Maverick trial, the S1914, S1933, and S1934 in assist. And then I'll talk about other champion trials as well. So the Maverick study by Chad Rustoven, who I don't see in the room right now, this is MRI surveillance plus minus PCI for small cell lung cancer. So either limited stage or extensive stage small cell lung cancer. So basically those who are getting, so really everyone gets MRI surveillance in the same way, every 3 months for the first year, and then every 6 months after that for 2 years. You stratify by limited versus extensive stage by whether they get immunotherapy and what their performance status is. Meant to be very practical trials, so they allow for hippocampal avoidance if you want to. You can have surgery if you want to for the thoracic tumor. Really any kind of definitive treatment is okay. Really any kind of fractionation as well. So really meant to enroll almost everybody possible. This has been accruing somewhat slowly but steadily. So they're about 114. I think he told me 115 yesterday out of 600. They've been talking about whether or not they can decrease this. If they've been working with NCI to try to get these numbers down a little bit more towards the 200, 300 range, given that this is that's what the previous PCI studies had looked at, and potentially changing the outcome to cognitive, to some kind of cognitive outcome rather than overall survival. But that's still in the works. But still, we actually had a patient accrued this past week at Yale, and this is still ongoing, but need some help to continue getting closer to the goal. NRG S1914 is Megan Daly's study here, SBRT plus minus atezo in stage 1 non-small cell lung cancer. So this one is looking at, this is a phase 3. Patients are getting immunotherapy up front if they're on the immunotherapy arm, and then they get SBRT, a total of 6 months of immunotherapy. And if you're not in the arm, you get SBRT straight up. So it's a non-placebo controlled trial. This is actually different than the other 2 trials that are currently ongoing in the SBRT and IO space. It's also a shorter regimen as well, only 6 months as well. This is really picking up its pace as well. I think in the 130s now for accrual, and I think Megan, you were saying about 9 per month recently, which is going much better than the first 2 years. I think a lot of it was given that places had trouble opening this, given that this opened in March 2020. We all know what happened then. So, but since then, we've been able to open it, and then other places as well to really hopefully amp this up further. This is specifically for higher risk stage 1 patients, so at least 2 centimeters or SUV of 6.2, or if the grade is listed as moderately differentiated or higher. So SWOG 1933 is for borderline performance status patients, stage 2 and 3. This is an important population that we see quite a bit of people who are, and this is only a 47 patient study they need. They're over halfway through, so it's picking up. And it kind of started slow and picking up now. Really for stage 2, if you have ECOG of 1 to 2 status, or stage 3 ECOG 2. But I think the highlight that I didn't realize till recently was the stage 2 ECOG 1 patients, right? I think we have some of those patients sometimes who come through who don't really want surgery necessarily, or not great candidates for surgery, but still a reasonable performance status. Or, the more common thing is probably, the other common thing is ECOG of 2, where you're kind of hesitant to give them chemo and to give them chemo RT. The issue here is that it's 60 and 15, so you have to feel comfortable with doing this regimen. But really, in reality, it's 45 and 15 to most of the central sites. So they're pretty conservative with how you can dose paint, to 45 grade and 15 fractions to the central structures, and 60 and 15 to everywhere else. So I think the main point is not to get scared away by the 60 and 15 regimen here. But then it's a single arm study, so they get the RT first, and then they get a Tezo afterwards. So pretty straightforward. The SWOG 1934 study in the cyst, unfortunately, they have not accrued yet. We're having lots of meetings about why this is the case, and if there's anything else can be done about it. The main issue is it's superior sulcus. On both arms they get radiation. So Rayo has been asking us to, in the radon and surgery groups, to really emphasize this point that this is for everyone, is getting chemo, RT, and surgery. The question is, do you add immunotherapy for this population? There's a long history at SWOG for studying superior sulcus tumors. Really, all the data we have right now is from SWOG on this so far. It's only a 60-patient study, but it's an orphan disease, but one that we just don't see a lot of, frankly. Really, the expectation is probably most sites will only get 1 or 2 patients on it max. And it's hard, of course, these days to open a trial when you don't have when you're not planning to accrue a lot. But there's some overall different approaches the group is trying to take to see if we can improve this somewhat. So in terms of the champion studies, Punitha study is currently on suspension since last November. Actually, it's already been about a year. It was actually a planned interim analysis, so we're kind of waiting to see how that's going to turn out. But this one is for oligometastatic patients who have up to 3 sites of kind of limited metastatic disease. They can get the key here is that they can get immunotherapy as well. The previous studies so far they've been published from Gomez and others have shown that this works after chemo, doing consolidated radiation for oligometastatic patients, but we don't know in the IO era if that's the case. So it's been accruing reasonably well, and it's on an interim analysis now. But we'll see if it reopens. Then we'll let you all know. LU005 was really a success story for NRG, and SWOG as well has been contributing some patients to this. This has completed accrual in Canada and the US now. This was and it was faster than expected. So kudos to the investigators for this. This was for limited stage small cell, looking at chemo RT plus minus immunotherapy concurrently. So similar to the ECOG study for the non-small cell patients. But this had a lot of interest. This was also designed very pragmatically. So I think a lot of lessons to be learned from this. They let you do chemo, first cycle of chemo before study entry, which I think was really a great idea. They can do any fractionation that's considered standard currently, the BID or daily. And then you don't even have to get the PET CT before, because a lot of times these patients, you see them inpatient, and then they get the PET CT afterwards. So they really allowed for a lot of those things and accrued very well. They're still open in Japan because they pre-specified that they had to have a certain number of Japanese patients on the study. So they're allowing, they're going to keep it open until 45 Japanese patients end up accruing. But otherwise it's closed in the US, and hopefully we'll have some interim results in the coming years. LU006, the imprint studies from Andreas Rimner. This one is accruing slowly. Again, a similar idea that this is a very rare cancer. Only certain centers tend to see these malignancies. So opening these at the high volume centers is really important. But this is the idea here is do the surgery is pleurectomy and decortication, and then any adjuvant chemo. And I believe they have an amendment recently for IO as well, where they may allow for that too. And then the question is, do you do adjuvant radiation or not? And if you do the radiation, is IMRT. So it's a good study, but one that is difficult to accrue to given the rarity of the population. But again, an orphan disease. LU007, I'm the study champion on this. This is run by Quinn Nguyen over at MD Anderson, the RAPTOR study. So this is for extensive stage small cell, looking at the idea of do you, in the era of chemo and immunotherapy now for extensive stage small cell, do we still have a role for consolidated radiation that we did before immunotherapy era? But this goes a step further to say not just necessarily thoracic radiation, but also up to 5 sites of treatment overall. So you can do complete consolidation, meaning treat all the sites of disease if you can or want to, and you don't have to either. So you could also do incomplete consolidation. That I believe is it's not a stratification variable, but they are going to look at that as part of this trial. They're accruing slowly, but they activated about 2 years ago. But of course, during the COVID times, it's picking up a bit more. It's at 34 now. The phase 2 component needs 138, so it's a little bit slow. But the good thing is that they do allow for co-enrollment with Maverick, so you can knock 2 birds with 1 stone on the same patient population. For extensive stage small cell patients can be on both this and the Maverick study. So just remember, Maverick and Raptor both have the cool names to them. But then the other good thing for the Maverick study, back to that, is that, because LU005 closed, they actually couldn't co-enroll with Maverick. So now that all those limited stage patients who are accruing really well to LU005 no longer have that as an option, Maverick's really going to be the only kind of the only NCTN trial left in that space. And in extensive stage, there's 2 trials, but they're both allow co-enrollment. So they worked well together on that. So I just wanted to point that part out. The other thing I wanted to point out about this study is that the Amendment 3 is processing now. It should be approved soon, which is going to allow for patients with brain mets. So of course, with extensive stage small cell, a lot of patients had brain mets. They were previously excluded, lost a lot of patients on that. So we'll include those as long as they can get whole brain, which I know is still controversial, but those patients do have to get whole brain, given that the concern about the endpoint being PFS, they don't want to be getting more intracranial recurrences if you just gamma knife. EA518, one I mentioned in my talk earlier. So this is the consolidated versus concurrent to doing IO with chemo RTs. So accruing really well, 425 out of 660. Even 6 months ago, this is down in the low 300s. So if it keeps going at that rate, it should be done by next year, which I think of it will be ahead of schedule. That should be interesting as well. And then the Lion study, this is by Stephen Schild and SWOG champion is Arya Amini. This one is looking at advanced non-small cell lung cancer PD-L1 negative with performance status 0 to 2, with the idea that you're either randomized to either getting IO or chemo IO, with or without SBRT, with a lower dose, say equate times 3. Similar idea to the Raptor, where phase 2 endpoint is PFS, phase 3 endpoint is OS, with the following stratification factors. So that's basically all I got here. The main thing I want to show is that we have a lot in the NCTN right now in lung, which is cool. There's almost something in almost every part of the spaces, and we talked at the subcommittee today about where other gaps there might be, but there's quite a bit going on. So and this here being the resectable population is the for the locally advanced here. There may be a gap there as well. And then for progressive disease, like Arya Amini has mentioned before, we're working on, he's going to continue working on that with the lung committee. So there's a lot here.
Great, thank you. And Dr. Daly's here. Did you any comments on was it Maverick or anything like that, or anything you wanted to add about your study? Go back to
I think Henry did a great job of summarizing there. In terms of my trial S1914, we were very slow the first 2 years, well behind schedule. Our target has been 8 patients per month, and we were down around 4 or 5 for a lot of that. The last 3 months, knock on wood, we have been around 9 or just over 9 per month. So I'm hoping that is a permanent upturn. We've had several higher volume sites open the study. And we still have a couple of more that are getting ready to come on board. Kaiser Northern California is going to come on board momentarily, and it sounds like Peter Mac in Melbourne is also going to come on board. So, we're very optimistic, but we do need to make sure that we complete accrual before Pacific 4 reports out. Otherwise, we kind of lose our window, and they are well ahead of us. I don't think there's any way we're going to finish before they finish, but we need to finish before they report out. So if there's any other sites that are on the fence about opening it, I'd be happy to try and convince you to.
Great. Thanks, Dr. Daly. And I see Dr. Amini here too. I don't know if you want to talk about the study you're championing. Yes. Or-
I think it's a great trial. I have a bias because I'm SWOG champion on it, but I think it's a cool trial. It's based off of early phase 2 data that the PD-L1 negative patients didn't really respond well to IO or IO-based chemo. So really flexible on the systemic therapy options, which is what you need to take home to your medical oncologists, because they're really the ones that are going to capture these. I think the hardest thing about this trial is that we don't see these patients, our medical oncologists do. So every week I send a nice, or maybe every other week, I send a nice email reminding them of this study. So any systemic option, PD-L1 negative, and then SBRT, it's a low dose to any site within 60 days of randomization. So just encourage your medical oncologist. I think it's a really exciting trial. Thank you. Advanced stage disease, what do you mean? So it's technically stage 4. They will allow some stage 3, I believe in there, but it's really metastatic stage 4. Any number, you could have 50 metastatic sites, 3 sites. And you can treat any number of those? Just one. So the idea is actually to stimulate an immune response for these PD-L1 negatives, so being like that spark for the fire kind of thing. You could do the primary. They're really flexible on what you treat. So really anything, it just can't be in a prior. So say you had a stage 3 and now it became stage 4, you can't treat in the prior radiated field. So it has to be outside. But I think it allows a 6-month window from any prior immunotherapy or radiation. So you do have to have a little bit of a washout period, but so you might be able to accrue your stage 3 patients that then metastasize as well. Thank you.
Thanks, Dr. Amini. Dr. Constein has no updates for lymphoma, so we'll move on to Dr. Wuthrick, who I think is online.
Hey, yes, good afternoon, everybody. You hear me okay?
Yep.
All right, great. I wanted to give a little bit of update of things going on in the SWOG Melanoma Committee. Next slide. So there's actually been 3 recently completed SWOG studies in melanoma that we're excited about, and several of them have some early readouts. So there was a phase 2 study of anti-PD-1 immunotherapy in patients with locally advanced and metastatic desmoplastic melanoma, which the early results have been presented at ESMO and do show that, as we suspected, desmoplastic melanomas are very sensitive to immunotherapy and have much higher rates of response than the typical 50-50, 55-45 kind of response to the other types of melanoma. And then there was SWOG 1607, which was a TVEC pembrolizumab trial in patients with refractory melanoma. We haven't gotten data yet on that study, but it's now closed. And SWOG 1801, which was a study that actually really has probably changed clinical practice the most, because it was a neoadjuvant versus adjuvant immunotherapy trial that was just presented at ESMO. And I have a few slides about that towards the end. So next slide, please. All right, and then just a quick view of the cooperative group melanoma landscape. So there's a ECOG Akron study called 6141, which is a trial of ipi-nivo plus or minus sargramostim in patients with metastatic melanoma. And then there's SWOG 2000, which is a phase 2 trial, which is for patients with brain metastases that have BRAF mutation. And it's a question of whether it's better to use MAP kinase pathway inhibitors and immunotherapy, single agent anti-PD-1 immunotherapy, or whether it's better to use ipi-nivo as a way to delay the use of surgery or radiation therapy in patients with asymptomatic brain metastases and melanoma. And then there's a surgical study in SWOG called SWOG 2015, which is MELMART, and it's a 1 centimeter versus 2 centimeter wide excision margins in excising the primary melanoma, which may not seem like a big deal to you, but if you have a melanoma on the face or something like that, it could really make a big cosmetic difference, perhaps, and let us know if there's any differences in local control and other outcomes with that. And then lastly, ECOG Akron also has a study called 6134, which is dabrafenib plus trametinib, then followed by ipi-nivo at progression, or the other way around, ipi-nivo followed by dabrafenib trametinib. So basically, it's a question of like timing of whether to use MAP kinase pathway inhibitors first, or whether to use dual agent immunotherapy first in patients with BRAF mutated metastatic melanoma. Thanks. Next slide. I also wanted to highlight they're still going on, I think about 3/4 accrued, maybe somewhere between 2/3 and 3/4 accrued. ECOG Akron study called STAMP surgical treatment and the adjuvant Merkel cell carcinoma. Basically, this is for stage 3 patients after surgery. They get randomized to either pembrolizumab or observation. And we'll get some good information on whether we can use anti-PD-1 therapy as a way to prevent recurrences in stage 3 Merkel cell carcinoma. All right, next slide. And then we've been kind of busy looking at a secondary analysis that I presented some of this data, I think, the last time in one of our previous calls. But basically, we did a secondary analysis of SWOG 1404, which was a randomized trial which compared either what was old standard of care immunotherapy, either high-dose interferon or ipilimumab, kind of changed during the course of the trial, versus pembrolizumab in patients with resected melanoma, so stage 3 and stage 4 resectable. It was a huge trial, 1,300 patients. And in that trial, interestingly, adjuvant radiation therapy and whether to use it or not was left up to the treating team's discretion. And so we wanted to look at those patients who were treated with radiation therapy and compare those with look at their risk factors and compare them against those that were not treated with radiation therapy, since that was a decision that was made by the individual teams, and see what that looked like. Next slide. And what we found, and for the full data, come to Astro and come into the oral presentation of the sarcoma melanoma section. We'll tell you all even more about this, but in brief, we found that among all patients, regardless of how big their nodes were, whether they had extracapsular extension, if you have postoperative radiation therapy, you will significantly reduce the risk for time to regional recurrence. Among all patients, 9% regional recurrence rate at 4 years versus if you have no radiation therapy versus 1% at 4 years if you do have radiation therapy. Now, whether that 9% is enough in this unselected population to treat them, it's certainly a debatable question. So, but it does show that radiation therapy does significantly reduce risk of regional recurrence, just like the TROG 02.01 study. So it's basically kind of updating that randomized trial and saying that there still is potentially a value to adjuvant radiation therapy even in the newer immunotherapy era. Next slide. Although because a lot of the recurrences tend to be distant, the recurrence-free survival was not significantly different. Next slide. You can see, though, that if you look deeper into the data, there is a not quite statistically significant difference, but a difference between those patients that got treated with neither radiation therapy nor anti-PD-1 therapy versus those that got both. So that's the black line here versus the blue line. So, these hazard ratios and p-values are, bordering on significant for recurrence-free survival among those at highest risk. Next slide. We also looked at the different radiation therapy regimens. So the two most popular, of course, were the TROG regimen, 48 gray and 2.4 gray fractions. And the second most popular was the MD Anderson hypofractionated regimen, 30 gray, given 5 fractions semi-weekly. And then there were a host of a couple other regimens that were used, 60 gray and 30 fractions, among others. And you can see that the number of regional recurrences are so low, you can't make heads or tails out of it, except to say that if somebody was treated with what I would consider one of the standard regimens, like 48 gray and 20 fractions, or 30 gray and 5 fractions, we had 0 recurrences among those patients. Next slide. Okay, so come see more about that at Astro. I also wanted to make people aware, because this is sort of an interesting study, and it might inform us about how other adjuvant versus neoadjuvant studies can be done. It's really cool phase 2 study with a primary endpoint of event-free survival, looking at resected, again, stage 3B and above, and stage 4 melanoma. And they were randomized either to neoadjuvant immunotherapy with pembrolizumab 3 cycles, then surgery, and then pembrolizumab out the back for the remainder of the year versus just going to surgery directly and then adjuvant pembrolizumab, which would be more the standard of care. Next slide. Event-free survival was used because we thought that things like progression to a toxicity that rendered the study participant unable to receive surgery was also something we should look for, in addition to melanoma recurrences after surgery and death from any cause, and as well as failure to begin adjuvant therapy. So if people are, after the surgery are too beat up because they had adjuvant immunotherapy or had neoadjuvant immunotherapy or something like that, that was something we also wanted to capture. So we used an event-free survival kind of primary endpoint. Next slide. Really interesting, what we found is that when you got the tumor in the body, the event-free survival is actually even better. So 72% at 2 years versus 50%-ish for the adjuvant. So this is really going to change stage 3 melanoma, I think. And you're going to see patients getting treated with neoadjuvant therapy if they present with palpable lymph nodes. Next slide. And the overall survival data is not mature enough, but even in the first couple of years that we may even be able to see perhaps even a survival benefit might be starting to emerge between these two lines just by getting the immunotherapy up front with the tumor intact before surgery. Next slide. And it seemed like the neoadjuvant group just benefited just about everybody. Some of these groups are too small to be statistically significant, but it doesn't seem like there's, whether you were BRAF mutated, whether you had a very high risk primary or a more low risk, stage 3B staging, everybody seems to benefit from neoadjuvant therapy. Next slide. In case you're interested, here's a waterfall plot, and I show this because what I think we need to do with radiation therapy in the future is, I think basically all these macroscopically node positive patients are going to get treated with some form of immunotherapy right now, single agent anti-PD-1, but it might evolve to newer or combination immunotherapy drugs in the future. And if those that had great responses, the complete responses and the partial responses, those probably aren't going to benefit from a local therapy like radiation therapy after their surgery. But what I'd like to focus on is that latter third, all these ones without a great response. Well, I wonder if we could potentially benefit patients in that group with postoperative radiation therapy. So that might be the future of nodal basin radiation therapy, because we've been unable to really identify reliably a group of patients who's at such a high risk of regional recurrence without being at a high risk of distant disease that we can really make a dent in the recurrence-free survival, which is where we really want to impact that outcome. Next slide. Okay, this is just a few other details about the study for you to review, but I think the major finding, which was presented at ESMO, was 2-year event-free survival, 72% versus 49% in the adjuvant arm. So, next slide. So that's all for the melanoma group. I'd be happy to take any questions about the data I presented.
Great. Thanks, Dr. Wethrick. Any questions? All right, very interesting stuff. We'll move on to the NCORE symptom control and survival. Dr. Cook, are you online?
Yeah, I'm here. Can you hear me?
Great, yep.
Okay. So this will be quick because, again, most of these studies don't have a radiation component, but I figured I'd just give a quick overview of what's going on in these committees so people can get a flavor. So there's a few active studies in the Symptom Control and Quality of Life Committee. S1600 is phase 3 study looking at immune enhancing nutrition on patients who are getting radical cystectomy. 1614 is a prophylactic antiviral therapy in patients with the current or past Hep B infection who are getting chemotherapy, but they weren't really able to accrue on this trial, so it's likely closing, unfortunately. iCheckIt has been going on for a while. It's an observational study looking at immune checkpoint inhibitor toxicity. Next slide. In terms of developing studies, 2010 is looking at patient education and active symptom monitoring to improve adherence to endocrine therapy in young patients with breast cancer. 2205 is a peripheral neuropathy study looking at limb compression and cryocompression, a variety of different techniques for that. There is a possible likely upcoming study which will require some of our involvement. This is a study that came out of the Young Investigator Training Course, Dr. Retta Males. It's a randomized, well, the concept is a randomized phase 3 double-blind clinical trial of probiotics for patients who are getting pelvic radiotherapy. Next slide. I don't know if you guys all get quad shot, but I saw this a few weeks ago, a randomized trial in Advances that was asking the same question, a small study, and showed a positive impact on patients' diarrhea symptoms when they're taking probiotics. So simple concept. I've been talking to them about it a little bit just to provide some initial thoughts, but likely, you know, someone, they're planning on enrolling GYN patients, so probably someone from this committee who treats GYN might wind up being involved. So I'll update everyone when it moves into the next stages, but this will be coming up eventually. Next slide. And the survivorship committee also not a lot that really overlaps with us, but again, just to give you a sense of what's going on, there's a study looking at carvedilol for prevention of cardiac toxicity in patients with metastatic HER2-positive breast cancer. 2204 is a perioperative physical activity intervention in older adults with lung cancer. And 1404 is the impact of immune checkpoint inhibitors on gonadal reserve. Next slide. And some of the upcoming concepts are intervening with caregivers to improve patient health outcomes and optimize healthcare utilization, GnRH analogs for protection of ovarian reserve in young patients with cancer, and continuous glucose monitoring to improve glycemic safety and reduce infection in patients with ALL. That's all I got.
Thanks, Dr. Cook. Any questions or comments? All right, and Dr. Connolly is going to give a brief update.
Yeah, so since I only was the only study that has any radiation component is mine, which is in the prevention, so I didn't want to go through that again. And there isn't actually anything else within prevention or CCD at the moment,
Great.
but next time I'll show you what is there. Sorry.
Okay, great. Thanks, Dr. Connolly. And we have a couple minutes, and I do see Dr. Ballas here, and her concept was the one chosen. I don't know if you want to talk for like 1 minute about the bladder, not to put you on the spot, but you know, where we are and all that stuff.
Hi, everyone. I'm Leslie Ballas, and I am very thankful to have be championing the first Radiation Oncology Committee SWOG study. It is looking at response-based radiotherapy, chemoradiotherapy, or radiotherapy with immunotherapy following neoadjuvant chemotherapy in patients with muscle-invasive bladder cancer. So the gist of it is that, oh, there it is basically patients with muscle-invasive bladder cancer who get neoadjuvant chemo as part of a package to go to cystectomy would, after their neoadjuvant chemo, if they had a good response, meaning clinical T0, T1 disease on cystoscopy, would then register for trial. They would then have a TURBT to confirm that that was the disease that was seen, and that would have template biopsies to evaluate sort of neighboring bladder to make sure that we're really evaluating response thoroughly. They would then go on to be randomized to either radiation and immunotherapy or chemoradiation. That site's a little bit old, but chemoradiation, which is sort of our standard of care option. It is not designed for comparison between the arms. It's actually designed in a statistical fashion similar to RTOG 0732, I believe is the number, but was basically looking at two randomized arms, and they had to each reach like a benchmark in that study, distant METs-free survival. And if they both reach that benchmark, then sort of it informed what the next phase 3 trial would be, or if only one reached the benchmark. And so that's how we're doing our statistics. Looks like it'll be 123 patients per arm, and things are moving along. The GU committee has been also very supportive, and the one thing that's been a little bit tricky, which I just sort of like for future radiation trials, is getting some of the statistics support, because we are relying on the GU committee's statistics support group, and they have other things in their queue. So it's a process, but my greatest strength in life is that I follow up on things. And so they're already getting sick of me, and I can only imagine by the time this is done how they're going to think. But anyway, that is one challenge that has kind of come up. But anyway, thanks for letting me talk about it.
Thank you. Very, very exciting. So that's it for us. Any last comments? All right. See you guys in San Francisco, May 10th to 13th. And thanks for a wonderful meeting.